Well, welcome everyone. We're so excited to have this meeting today. We believe the subject matter will be very worthwhile to everyone. And I'd like to thank John Meservey, Teresa Wilson, Stan Hunter, and our panelists for today's meeting. We are making a difference. And before we get into the meeting, I just want to invite everyone on this call to share any ideas and thoughts of interest they may have for future meetings. We know we're making a difference. As a matter of fact, we are now integrating many of the ideas that we have started through HAIO into a bed project at Newton Wellesley Hospital. And we'd like to continue our mission of saving lives and bettering lives through our efforts. So thank you all. And John Meservey, our president. John, please take over. Thank you.
Thank you, Richard. I'm thinking we could probably do a session on the best chocolate chip cookie recipe, but we'll wait till we get into the summer for that.
I've got one.
Okay. So we got a great panel today, and I think it's an interesting topic. It's about what have we learned. It continues the exploration of what have we learned through COVID, and what does it mean for this next generation of projects that we have, as well as renovations to existing space. And today we're going to be talking specifically about surge spaces around EDs in particular. And many of you, especially if you're associated with a hospital, you are experiencing tremendous patient surges and an inability to continue to move patients through the various stages from arriving at the ED to discharging them to either a subacute setting, or easier to discharge to home, presumably, but to a subacute setting. So throughput is significantly impacted, and certainly for the MGB system has had a significant financial impact. And I think others are probably facing the same challenge. So we wanted to talk about what's on the horizon, what are the limitations, and what we can do. And what are some of the thoughts and experiences that people are having in the ways that they're dealing with this in an innovative way. I think, well, we have a great panel, and I'll introduce them in a minute. Also looking for folks who are listening in on the call to introduce themselves in the chat. If you would like to say something about what you're doing at your place, or as a project that you're working on that you think the rest of us would be interested to hear about, would love you to let us know that you're willing to say a few words about that. And because of that, and then in the anticipation of there being perhaps more of a discussion in today's session than we typically have, I'm asking the panelists to keep our organized comments to about 30-40 minutes at most, and allow 20-odd minutes for discussion that involves folks in the audience. So today we have Chris Kennedy, who's Bay State Health's Director of Planning and Design. We have Dave Duncan, who's Dartmouth Health Systems Senior VP for Facilities Management. We have Rosanna Penny, who's the Haywood Hospital COO and CNO, and VP for Patient Care Services. So Rosanna's got multiple hats there. We have Troy Savage, who's an Associate Project Manager with Mazzetti, the West Coast-based engineering firm, although they have offices around the country now. And then Jim Crabb, who's a Principal Mechanical Engineer with Mazzetti, is in one of those other offices in Atlanta. Is that right, Jim? Yeah, okay. So why don't we begin the discussion? We as a panel had a chance to talk briefly last week, and just sort of get some ideas out on the table. But why don't we start with the hospital folks and sort of talk about the kinds of challenges that they're having with patient surge, and ways in which they're either effectively dealing with it or not effectively dealing with it. I know inside our own hospitals, we have a lot of folks who are on gurneys in the corridors surrounding the ED because we aren't able to move them upstairs. And that's a terrible situation. That's not the way we want to be treating our patients. And in reality, you can't really treat your patients when they're in that kind of a situation. So we've got our own sets of issues. We're trying to address them. But what are you seeing inside the hospital? And perhaps we can, Rosanna, if you don't mind kicking it off, what are you seeing over at Haywood?
Sure. So Haywood is a community hospital which presents its own unique challenges because we're not part of a bigger system with a tertiary center who could take our most acute patients. To that end, we have focused on trying to improve the flow within our organization, meaning that if we are at capacity or exceeding the capacity, we're doubling up patients on the floor. We're taking our private rooms and making them double rooms. We have brought patients from the floors that are waiting for discharge, but don't have ability to leave the hospital for various reasons to surgical day area to keep them there. And then our absolute worst case scenario is we open up HAIO. Our biggest issue is it's very difficult to transfer patients right now. So when our ER is completely full, there is no place for patients to go. Even for the tertiary centers, patients who need higher acuity, higher level of care, we've been transferring patients as far as Connecticut, which is pretty far for us. And another really big issue, which intensified over the last couple of years, is behavioral health crisis that is statewide. There are not enough behavioral health beds. Our own MHU unit had to close because we don't have enough staff. We tried throwing a lot of money out there to recruit staff, but it's such a specialized unit that it's very challenging to get people to work there. So we are focusing on flow and throughput on the back end. And then when that is all in play already, when we pulled all those levers, then we also send providers down to treat patients in the waiting room, try to get as many fast track patients out as we can. We send an extra APP out there to sift through the ER and try to get those people out as quickly as we can also. John, you're muted. I see your lips moving.
My lips were moving, yes. I was saying you're pulling all the levers, and it sounds like the same kind of things we're doing at the AMCs as well. Chris, what are you seeing at Bay State?
Yeah, I think we're seeing a lot of what Rosanna was mentioning. You know, I had sort of made some notes, and Rosanna stressed it as we sort of started with the focus on the ED, but so much of ED surge is directly related to that throughput, right? What's our inpatient bed capacity? How are we doing with discharges? So, it's a pure system. And as soon as there's a sort of backup in one of those lines, it impacts everything. And it always sort of seems to end at the ED. So yeah, we're seeing, plenty of surge. I think, a couple of things come to mind, right? We've lived through this pandemic for a number of years, so we've really been able to test a lot of surge scenarios. So, right, if we're speaking specifically about the ED, we were quite fortunate from a physical environment standpoint to have a space that we could quickly build, almost like a field hospital. So it was a little bit crude, but it did allow us to pick up about 5,000 square feet of just enclosed, environmentally conditioned space where we could, from an infection control standpoint, separate patient populations of those sort of presenting viral symptoms from those not presenting and just coming to the ED with their own ailments. So I think that makes me think a lot about as we look at surge and we look for spaces to accommodate surge, before we even find the space, what type of circulation will be impacted? Are we going to be bringing, patients with infectious diseases past patients without infectious diseases? Can we find alternate entrances and separate those populations? And we did that across the system, not just at the main campus, but also in some of our satellite hospitals where when it was really bad, right, our surgical areas were shut down. You know, could we create a separate emergency department waiting room for patients presenting with symptoms, create sort of one-way circulation pathways. From there, I think it then sort of leads to what options are available within the hospital itself. A couple of other things that come to mind is, you know, the surge, right? From well, first of all, right, we don't sort of from the hospital standpoint, you know, a lot of us represent engineering and physical environments, but you know, responding to surge and surge needs is multidisciplinary, involving, you know, everybody, at least representatives from every part of a hospital system, from clinical care to support services and so on. So, you know, we huddle as a group to get together and sort of identify, you know, what's the main issue, what are we trying to respond to, and then we break into our subgroups. So, you know, we were part of a team that represented the physical environment, but we were working with, you know, teams from registration, teams from, you know, that were treating the patients, from the EDs, from environmental services. And so we would bring our input to it and offer some of our solutions, but it was always taken in the larger context. In that larger context, as Rosanna mentioned, we identified the levers, right? When do we pull a lever that pushes us into an actual surge space? So I think it's just important to identify, you know, before you even get to how are we physically responding to surge, how are we defining surge? And that also accounts for the patient population that we're addressing, right? It changes, you know, through the past few years. You know, we had COVID. We've had surges in behavioral health populations, which presents a whole other, you know, surge challenge. If you have a behavioral health population with infectious disease, how are you accommodating them? It might not be the same. We've had pediatric surges, and then we've had, you know, this fluvid surge. So I think kind of knowing what we can anticipate for our patient population, all of the information and data that we gather at least helps us kind of move, you know, helps us define how we will respond to the surge. And it's, you know, it's rarely a one size fits all. So flexibility, you know, if I'm looking into the future, right, this group here has got a lot of smart people, a lot of brain power on this call. You know, we're looking for flexibility. To your point, John, we don't want to treat people in corridors. That's not ideal. I would love to walk away from this meeting with a better idea, because it seems like no matter what we do, you know, we tripled the size of our emergency department at Bay State Health 10 years ago, and it's been full ever since. So they just keep coming. And you know, if we could get away to a place where we don't have patients in the corridors, and we're doing something right. And I wish I had the answer to that, but it continues to be a challenge. And I think, you know, it's an interdisciplinary challenge that involves an entire system. So sorry, long response to your short question, but hopefully I brought up a couple of points for discussion there.
Yeah, I think the point that, you know, the surges are, it's not the same surge, you know, every day is not the same surge, you know, that there are events where you're seeing more behavioral health type surge, that there is an infection control surge, that there's a pediatric surge, and you know, it really has to do with sort of the mix. What's the predominant mix? I mean, you're seeing everything at the same time, but there may be days when you're getting a different type of patient, a peds patient rather than an adult patient, for instance, and it sets up a whole different set of challenges in how you deal with the peds patients separate from the adults, and then the behavioral health, of course, too. Dave, what's going on up at Dartmouth?
Boy, good morning, everyone. A lot of similarities. So let me kind of start with the surge stuff. You know, the emergency rooms have been difficult, but we had a discharge lounge, literally a button up to our emergency room, and we slid that discharge lounge out into public space and temporarily enclosed it, and converted our discharge lounge to ED overflow, ED holding. You know, and obviously some of the simple stuff, we had a conference room in the middle of the ED that we took over, and that became an ED holding area, and we put some utilities in there, some gas, some power. About 10 months ago, right in the middle of COVID, we opened a new addition to our ED, and it was a dedicated 10-bed behavioral health unit. And that gave us some reprieve, maybe for about 2 weeks. And then we got some press on it. And then we get bombarded with more behavioral health patients than what we could handle. So we started going, oh my God, we probably shouldn't have done a couple of those press releases. But and then related to PD, in there, right in the winter, boy, the PD patients coming in, and our emergency room was bonkers. And we have a dedicated inpatient PD unit and a PD PICU unit. And we took a pain-free clinic space that was adjacent to our PD unit, relocated that out, and we were able to make 4 more PD inpatient rooms. And those filled as we were painting the walls and stripping the floors. So that was an a surge issue. The PD surge has tailed off for sure. And then we had just bombarded in Dartmouth and Lebanon with these long-term care patients. We have about 400 patients a day in our hospital, and 80 of them should be gone to an assisted living, a SNF, a rehab, or home, where home health nurses could take care of them. But they're all shorthanded with staff, and we can't get these patients out of the hospital. And that's really, as you guys are all saying, is we've got 80 patients using our inpatient beds that should be someplace else, which then backs up surgery, backs up the ED, etc. Some of the unique situations that we're trying to address those long-term care patients that don't need acute hospital but need some care is, we have 5 sister hospitals, and we've gone in and looked at all of those sister hospitals, the smaller hospitals that shut down units in the last 10 years. And we're identifying and kind of creating a new term, board and care. So, we've got a small OB unit at one of our sister hospitals that's been closed for 6 years, full of boxes and some desks. How do we empty that out? And can we move some of our long-term care patients down there, use the food service, use the housekeeping services, and literally maybe staff it just with 1 nurse and an LPN, just so that the patients get out of the hospital and they need another week of care before they can go home. So that's some of the things that we're investigating right now. So John, a lot of similarities. These are some of the things Dartmouth's doing.
Well, at least you have some outlets in these closed bed areas that you're able to reopen relatively quickly, it sounds like, which is a wonderful resource.
Hey, John, we
sorry.
might have the space, but it goes right back to, where do we get that nurse? Where do we get the staff?
Yeah, exactly.
Push them. We think we could clean the space. We could, do another 10, 12 meals a day, but where do we get the clinical staff? So we're working our way through it, but it's far from over.
Yeah, that's a good point. I don't want to make this sound like it's only a space issue or a bed issue. It really is a staffing issue, big time. And I think some of us have beds we could open if we had the staff to open them. So it's not like we are totally out of beds, but we're certainly very thin on staffing, and that's not going to be easily addressed. Troy, let's sort of flip over to what the engineering, what you're hearing here. And actually, you made an interesting comment or observation after listening to us last week, and not to send you off on a tangent, but it really it resonates, and it's, our preoccupation is with the ED getting backed up, but that's a symptom of several steps further down the supply chain of patient delivery, if you will, where it's our real problem is moving patients out of the acute setting and into appropriate non-acute, when that's their, that would be their next place of care before they're ready to go home. And I don't want to lose that point, because I think we tend to focus on what's obviously broken in front of us, and that's our ability to move throughput through the ED. But it's a symptom of a bigger problem, which is throughput through each stage of care and out of the acute hospital. But Troy, what do you make of what you're hearing here?
Yeah, thank you, John, and thank you, everybody. I will leave the engineering to my colleague Jim Crabb, who is better equipped to speak to the engineering than I am. I think Teresa, thank you so much for inviting me to participate here. Teresa participated in reimagining the ED back in 2017, which is one of the reimagining workshops that I organize and facilitate. And recently, actually in December, we had another workshop, Reimagining Behavioral Emergency Environments, which happened at the National Update on Behavioral Emergencies Conference. I'm bringing that up because after a conversation last week, I had an opportunity to think about the ED and to revisit some of the ideas that came up in reimagining the ED. If you're interested, all of the ideas are incorporated into a white paper that you can get. You can just type reimagining the ED FGI in Google and you'll find the white paper. But the ideas that came out of reimagining the ED were really around improving arrival and front end operations. Some of the ideas in that category were creating a registration kiosk for low acuity patients, considering the ED as kind of a front porch, since in many cases that's what it is, and taking kind of an air traffic control type approach to thinking about the ED as the place where you're directing patients to different places, and then streamlining flow and front end processes. The second area from reimagining the ED was to reduce patients' length of stay in the ED. And so one of the ideas, and these are just ideas, right? So I'm just sharing ideas. But one of the ideas was to think of a conveyor belt model, specifically for your lower acuity patients, so ESI 3 to 5. And to, as opposed to bringing services to them in a room, moving your ESI 3 to 5 patients kind of through the ED from station to station in essence, as a way to potentially improve flow. And then there was a concept of having a dedicated section of your ED for your ESI 3 patients, which is typically the majority of patients that are coming into the ED, and using kind of the vertical beds, right? So the sitting beds, which was a big theme coming out of reimagining the ED, because there was a lot of work on that ahead of time. And then the third area was just ideas for improving the experience of behavioral health patients, creating behavioral health modules within the ED, or having a dedicated behavioral health ED. And I think I want to focus there because, as I mentioned, we just had reimagining behavioral emergency environments, well, 2 months ago now, workshop. And one of our main clinicians at the workshop, Dr. Scott Zeller, is also a big proponent of something called the Emergency Psychiatry Assessment, Treatment, and Healing Unit, or the EMPATH unit, which I'm sure some of you are familiar with. The concept of the EMPATH unit is really to just provide a space, a large space, where you can send behavioral health patients. So as Dr. Zeller points out, in some senses, behavioral health is the only acuity where the default is to send somebody to inpatient, right? You might not ultimately do that, but the default thinking is we need to send somebody to inpatient. Instead, like all other emergencies, a vast majority of them might be able to be dealt with acutely and then released. And so the EMPATH unit is kind of designed to provide a large space that allows people to be within a milieu, allows clinicians to come in and treat patients, and then either get them to the point where they can be discharged, or where they can be moved into an inpatient facility. And the good thing about doing the EMPATH unit, there's several advantages, but the one that I think is relevant here is for a lot of EDs. There's a throughput problem, and some of the throughput problem is around boarding. And the reason that you have a lot of boarding of behavioral patients is that it structurally doesn't work, right? As I said before, the default is to send them into inpatient places and there's not enough beds. the empath unit, I talked to Scott about this between last week and this week. Sorry, Dr. Zeller, and he pointed out that fundamentally, right, the empath unit is about providing a large space, about providing an empathetic as opposed to a coercive model of care, and providing a place where people in behavioral crises can have opportunities to talk with other people and to do some of the things that might help them through behavioral crises, so that you actually end up having, at least in his research, a less need for people to go into inpatient spaces. I think the reason I'm highlighting this, and I'll turn it over after this, is that if you have patients who are only having a behavioral crisis, right? So that's their only medical emergency, and you need to triage before that. Then you could conceivably create an empath unit without worrying as much about high levels of ventilation. You can do the normal ones and not the higher levels that you might need in other spaces. You might be able to do it within spaces in an existing facility that you're not using now, or you might be able to build something adjacent. And so the FGI 2022 guidelines does have a new section on behavioral health crisis units, which is there. And then Dr. Zeller, Virginia Pankian, Ariane, and others wrote a white paper on the spaces. And I think one final point, I think it's an example of what it might look like to think about spaces kind of a little bit downstream of the ED, and to think about the ways in which those spaces might be easier to convert, to build, not necessarily easier to staff, as everybody has pointed out. And so if we think about, to John's point earlier, the ways in which we might think of the entire system and alleviate some places of stress further down the line that are easier to do, it might help with the throughput challenge. Thanks, everyone.
Could I just add a point to Troy's great notes there. Thank you, Troy, so much for sharing that, and thank you for the reminder to just give thanks for being here today and sharing Bay State's story. It's real. I've been on a lot of these panels, so it's a real honor to be here today and be able to share our perspective at Bay State. And I apologize for not doing that earlier. So thank you, Troy. I just wanted to add to your point about the behavioral health borders from like an environment of care, patient experience. Having behavioral health borders, especially in sort of pediatric populations, which is like the most present or most recent experience that we've had, it's just such a disruptive environment for non-behavioral patient populations. So that like it just creates such an issue within emergency department settings to have backup and throughput issues with the behavioral health population when you start to have small children next to 17-year-old behavioral health patients going through a crisis. It creates a very, very challenging environment to provide care in, and that only sort of adds to the distraction and disruption. So I can't wait to read those white papers, Troy. Thank you for sharing. It's a real it's time to sort of treat this population in a much different way. Thank you.
Thanks, Chris. Jim, principal mechanical engineer at Mazzetti. You may have just heard Troy's trying to put you out of business. He says all you got to do is open the window and everything will be fine. That's enough ventilation. He's in your company. I can't say anything to him. But what are you hearing? What are you seeing from a big picture point of view about way in which these situations are being handled in the hospitals you cover?
Well, let me echo Troy's thanks first for being here. I feel like I'm sort of an outsider. All of you are so close to the front lines, and I'm a consultant to you. So my experience is more distant. But I can just tell you a couple of things. We have a client here in the Atlanta area that built a new hospital less than 10 years ago. Very nice new hospital, large patient rooms. They decided they wanted everything to be same-handed, and they put in excess medical gas and electrical outlets. So it basically duplicated on both sides of the head wall all the gases and electrical that was going to be needed for a patient. And so during the surge, they started looking at that and thinking, hey, this room is big enough. It's larger than a semi-private room would have been 20 years ago. And we have these access outlets and everything. So they're looking at how do they just move another bed into these rooms. So that's really pretty easy. It's about 200 beds in this hospital, and most of the rooms are set up that way. It would be fairly easy to double. But of course, all their staff areas are their staff areas, and all the food service is the food service, and the staff is not necessarily sitting around waiting for an offer to come in and work there. So they have the same issues that everybody else has with all of those things, but they at least have a space where they could do some surge. Another facility where we work, the Emory University Health System has a hospital that they built, perhaps a little bit overbuilt in an area. It's about 15 years ago now, and they ended up shutting down some of those units. So much like David, it's relatively new facility, and they were able to simply open up some of those units. Simply, they had to staff them, open up those units and handle some surge. But it strikes me in all these conversations, well, two things. One is the throughput that we've been talking about. It sounds like the issue is at the far end from the ED, but it shows up in the ED. So if we can, from a mechanical perspective, it strikes me that making surge space available for patients that probably should be discharged anyway, or at least that are at a relatively low acuity by that time, is a lot easier than making surge space for emergent patients that you're still trying to figure out what the issues are, and they probably need a lot more service. So that should be easier. Staffing is still an issue, but the main issue, it seems to me, is in planning. I served on the FGI committee for the alternate care sites for the emergency conditions, as did, 100 other people. A large group, which is probably why it's a 700-page document. But the real focus of that was you need to figure this stuff out in as far in advance as you can and have a plan for where you're going to do these things. The situation will be different each time. COVID was not something that people were really anticipating necessarily. And sometimes the emergency condition is a mass casualty, and that's a completely different kind of thing. Or the mental health things that crises that come up. But if you've planned for these things, you can run through the scenarios. Obviously there's, I think it was Chris that pointed out, this is a real joint effort between facilities and operations, clinical. But you can run through, we've seen a lot in the last few years, so we have good information about what our needs might be, and we can start planning for it. And building that plan seems to me the best way to plan, to be prepared for what you have to do. But if we can do the kind of things Troy's talking about and remove those mental health populations from the EDs, that strikes me as a real benefit. I assume everyone else is seeing the same sort of growth in mental health needs that we're seeing here. I haven't done a new mental health facility in, most of my career. I've done just a handful, and now suddenly it's happening again. So that speaks probably to both need and funding, which is another aspect of this that we haven't really talked about yet.
Yeah, that was an interesting observation you made, Jim, that I hadn't thought about, and perhaps others haven't thought about too. But it just, if you're looking to organize space, if you had the luxury to create new space inside the hospital, you wouldn't necessarily be putting it into beds. You'd be putting it into surge space around the ED entrance to the hospital, and you'd be putting it in the surge space at the back door, if you will, where discharge is happening, and so that there's an ability to hold patients appropriately in a surge space in the ED, and obviously that speaks to different tracks and triaging and separating out behavioral health, and perhaps even being able to treat them there without them even needing to get into an inpatient setting. And then at the back door, an ability to house patients who don't belong in a high acuity bed upstairs, but don't have the setting, that the subacute setting is not available to them yet, but that you've got some way of caring for them in an appropriately staffed setting. So it's an interesting concept. I mean, as putting on my architect, diagrammatically, it almost sounds like you want to pull the ED outside the footprint of the hospital, and you want to pull something that you might call a discharge. I don't know. I know we have discharge lounges, but discharge suite out of the back end of the hospital, and have space around them. Obviously, there's a lot of connectivity that's needed to both of those spaces to support their activity, but it gives you a lot of flexibility to grow and expand, to grow or shrink or whatever you need to do. Probably the most flexible types of spaces that you would have in a hospital to accommodate the different types of populations that you're going to be serving over time, and certainly an ability to house pediatric patients separate from adult populations too, which I think we all struggle with. But so many of us are using, even in the new hospitals, the EDs are embedded inside the footprint of the hospital proper. And that's the case in many of our legacy hospitals. A couple of them where we've been able to build new EDs, we've been able to build them outside the footprint of the existing hospital. And I think that gives us flexibility for expansion and to address some of these issues, although we haven't figured out exactly how to do it yet. So interesting idea. So what I'd like to do is, Teresa, I don't know if anything's come into the chat yet, or if there are any other folks on the call aside from the panelists that would like to make an observation.
So Sarah Markovitz has sent something
hi, Sarah.
in, and about hospitals offering hospital at home programs and helping with surge capacity challenges.
Yeah. Sarah, are you there? Do you want to say something?
Yeah, I've just been reading some articles about hospital at home programs that seem to be successful in various parts of the country that send providers once or twice a day to people at home, and that seems to, lower cost, keep people happier where they are getting care and keeps people from taking up a bed. Of course, it does require staffing personnel too, but I don't know whether that's a realistic program on how large a scale, how it scales up, and whether any of the people who are representing facilities here have looked at those programs and how successful they are.
Well, it's certainly on folks' radars. Vinny, without putting you on the spot, is there something you'd like to say about what's being thought about inside MGB?
Yeah, sure. Hey, Sarah, and I just threw Sarah a note in the chat. I don't know if it went to everyone or just to her. And I'm not sure if there's someone more qualified from MGB to talk about hospital at home, but here goes. We are very much engaged in a hospital at home program at Mass General Brigham. We see it as a significant potential for us to do exactly what you had outlined, Sarah, in terms of alleviating capacity. But the data also shows through the research that we've been doing, along with other systems across the country, to benefit the patient so that they're not placed in the hospital setting. There's a set of conditions of about 25 different things that we think we've mastered in terms of being able to treat in the home, even though these patients qualify for an inpatient stay. And we are being reimbursed on an inpatient level and treating these patients in their home with literally delivering a bed, and the technology that goes with monitoring these patients remotely, combined with all of the necessary services from a physician to a nurse to a paramedic to home care, and so we have been working at it for a couple of years. The biggest issue has been the threat to reimbursement. And just recently, the Medicare extended the program for another 2 years. So MGB currently has, Mass General Brigham has approximately 20 patients on service in its immediate area between Mass General and the Brigham. We intend to grow that program rather significantly. And we see this as a tremendous opportunity to essentially create a hospital at home, the size of, say, Newton Wellesley, 220, 200 patients on service without having to construct a Newton Wellesley. So as you might imagine, the capital cost or capital avoidance is significant. And that's not to say Newton Wellesley doesn't need to be upgraded. I have that on my list also. But this is a way for us to expand and treat patients in the setting that benefits them most. Avoiding hospital-acquired infections is sort of top of the list. So yeah, we are very much invested in the program, in growing the program. We've got a team of resources that have been added, and we intend to expedite the growth of this program to help alleviate in the short term the overcrowding of our hospitals with patients that don't necessarily need to be there, and who, through the research that we've done, recover better at home, in a setting that has a social network of people. There's criteria you have to sort of meet to get there, but in the end, it's better for the patient, it's better for the hospital, it's better for insurance companies, and we intend to fully, maximize the opportunity in this space.
Thank you. So just for folks who, Vin McDermott is the Chief Financial Officer for the Community Hospital Division of MGB. So that, other than the Brigham and Mass General, everything else is in the Community Hospital Division. Well, I guess the specialty hospitals aren't yet, are they, Vinny?
Not yet. But
yet.
yeah, essentially everything else outside
Everything
of
else,
Mass
all right.
General and the Brigham.
Yeah. Thanks, Vinny.
Hey,
That was great.
Hey, John,
Yes,
this is George Blair.
Hey,
If I
George.
could just add one other thought too.
Sure.
So, the overcrowding in the hospital, it's really important to get people out. So discharge lounge for everybody is, it could be new for some. People are trying to maximize and use it as best as possible. But there's patients you have to send in an ambulance. There's patients you need to send in a chair car. And then we tend to lean on, Lyft or Uber. But Lyft and Uber only gets the patient to their driveway. And we've actually partnered with our valet service to stand up a couple of what we're calling care vans. They will actually get a patient home and across their threshold. So in their front door and maybe on the couch. So that started to alleviate some congestion. It's not 100 patients a week. It's probably in the 10s and 20s. But that's 10 and 20 more beds that we can take advantage of. So it's just another thought for facility leaders to think about, working with their valet service or partner to try to help alleviate some of the congestion for beds.
That's really interesting, George. So basically you were saying some folks just felt like they weren't leaving because they couldn't get home. Is that what you were saying?
Yeah, and we're doing this at a number of the facilities. The 2 AMCs are, and MGH is using it for more frequent, kind of shorter trips. We tend to be using it for more longer trips. We've driven patients all the way down the Cape, all the way up to Maine, into Rhode Island. So we're taking long trips where a chair car from an ambulance service might be out of commission for 6 to 8 hours. We're just using a valet service and a van. So it allows the chair car to continue to drop patients off where they need to be. And we're looking to expand the service and how we can, and maybe even possibly stand up a couple of chair cars on our own. So it's still developing, it's still growing.
Sounds fascinating. It's okay, Patrick, we don't deliver to New Hampshire.
So John, there's another question. I'm just talking about behavioral surge that's in the ED is maternal behavioral health patients.
Yeah.
So, breaking the specialty down even more.
Who made
Sorry,
that
that's
comment?
Williams. I'm not quite
Hi,
sure.
I'm Marvina Williams. I was just saying that on some of the projects I'm working on, they're seeing a surge also in maternal behavioral health and trying to deal with placement for those patients and being able to do the telco exams and everything that's needed, but also to provide, like the swing type of bed for them in the ER so that they're safe and the patient's safe. So it's an interesting challenge.
Thank you.
I was actually going to comment on that telehealth, but what's, specifically to the behavioral health population to play off of kind of what Vin had mentioned from an inpatient at home. I think, having something like treating our behavioral health population with a teledoc, who knows how many people that keeps out of the emergency department. And so I think we really sort of need to, it's one population that I think really responded well to telehealth. Where we can meet the patient in their homes, in the comfort of their homes, and then, with the hopes of them never even stepping foot in the door. So it's interesting to think about telehealth, what will survive the pandemic and sort of be kind of common practice. And then, for this group specifically, like, well, how do we create spaces that allow us to accommodate and promote telehealth so that the patient at home feels like they're getting, true, honest services. And at the same time, we're kind of using that to, maximize our ability to use the physical spaces and direct those resources to where we need them.
One thing I'd like to add is, as we're talking about planning for surge spaces, to keep in mind the staffing space, because we saw this during COVID. A lot of staff had to be here days on end. So we need to make sure that they have a place to shower, especially if we're opening up surge places. Then we have to make sure that there's a place for them to grab a bite to eat that's really close to the clinical area because they can't go too far. And then also we should start considering quiet spaces for staff where they could actually get away from the clinical area altogether. Because right now we're really focused on getting patient space, but everybody is saying we don't have staff. And a lot of people are leaving healthcare primarily due to burnout. If they don't have any space to decompress or a gym space or get outside space, then it will only intensify the burnout.
Yeah, that's a excellent point. And I think we're increasingly acutely aware of the support needs of our staff, especially on the inpatient units. And it was a challenge during the early months of COVID to figure out how to set up safe spaces for staff, even to eat. Vinny, I see your hand up.
Yeah, without sounding like a commercial for New England Life Care, but and in full disclosure, I'm on the board of that company representing Mass General Brigham, and this is Pat Jordan representing Dartmouth Hitchcock, and I'm not sure if there's others. To follow up on Chris Kennedy's point about virtual care and the avoidance of an ED visit, it made me think of the services that are provided by New England Life Care. And they do exactly that. As I mentioned, the home hospital program, there's probably at least 10 overlapping services that we actually contract with New England Life Care to provide to our patients, even as part of our home hospital program, because those are very similar. Those are the cases that can be treated at home. We also use New England Life Care to do exactly what Chris said, avoid the ED admission. And if we can dispatch one of their nurses to the home to check on a patient that might need an infusion of antibiotics or nutrition or whatever it is, Remicade, they can get that without that patient having to come to the hospital, be diagnosed, stay there as an observation patient, clog up an ED bed, or worse, happens late on a Friday, and then they get admitted to an inpatient floor as an observation, and then they don't go home until Sunday or Monday. It's utilizing that service, and I encourage you, because probably many of you in the hospital business are probably members of New England Life Care, but utilization of this type of service is critical to help keep patients out of the emergency room that don't need to be there and can be safely treated in the home. And the New England Life Care model, again, not a commercial for them, but it ends up benefiting your hospital if you're in the cooperative and through an equity model. So just another way to sort of save pressure on the ED, the burnout of these are like lower level cases. And it frees up capacity both in the emergency room and ultimately those patients don't make their way to the inpatient floor.
So John, we also have a comment from Paula Buick about staffing, and maybe she'd like to speak to that.
Hey, Paula.
Hi, John and Teresa. At the MHA conference, they talked about the workforce crisis. And I'm wondering, how do we know that are people measuring the quality of care provided in surge spaces? I mean, I'm just wondering, staff are already feeling overworked and stressed and are suffering in the workplace, as Rosanna commented, and as Sarah said, the FGI are providing some guidelines to support that. But is anyone doing anything other creative about the workforce pipeline in their institutions?
This is Marvina again. I was basically doing a lot of outdoor green roof where people can, staff can get out, and it really helped. I know at UVA, when they had so many COVID patients, just being able to get out, take off that mask for a few minutes, and then go back in, the staff said that was so important to them and helped them quite a bit. And it's also been a recruitment and retention tool for them.
We had a similar experience at Bay State as well, where initially we had set up tents for staff to sit outside and just get that break. And when we recognized sort of how popular they were, we turned it into a capital project to create sort of a landscaped, covered staff space at each of the hospitals. So we have pavilion. We're working on a project to install pavilions and places for people to sit in either groups or smaller groups, charge their iPhones, and just sort of get outside in the sun, get some fresh air. At least for 2 seasons out of 4 in New England, but still they're popular, and we wanted to sort of recognize that for the staff.
And Michael Joyce just put a comment. He's from HGA. So Michael, I don't know if there's anything else you want to add. It sounds like you and Chris are talking about the same thing.
Yes, thank you. We have been looking at this exact topic and a lot of facilities that we are involved in, including the notion of bringing quality care to both patients and staff in places that might deserve it. And I guess the question I have is there data that shows the improvement to patients in their, particularly in behavioral health, that can help the logjam or the clogging of these spaces? Do we see improvement in the movement of patients due to quality spaces versus the opposite of no natural light or just a jammed medical plan floor?
So you're talking about evidence-based design research data around that. It's a good question. I don't know if that exists. It's certainly worth, somebody's got time on their hands, they can do a search to see what kind of data comes up. But
sounds like a good workshop topic.
Yeah,
Troy.
Well, if there's enough content there, yes.
Yeah.
I mean, even just evidence-based design in general is an excellent topic for a workshop. But I think on that question, I'll look to close. I just want to give everybody a few minutes to do whatever they want to do before their next appointment. Any closing comment?
Can I just say one thing?
Yes,
There's
go
a
ahead,
ton
Teresa.
of great resources that have been put into the chat section from the panelists and other people. So if you're looking for those white papers, you can find the links in the chat.
Is there a way to dump that out and include it in the minutes to the meeting minutes you send out?
Yeah, I think we can do that. I've been copying them so I
Yeah.
can put them in.
Okay. Because I think as soon as we shut down, that chat data disappears. All right, thank you, panelists. Thanks for kicking off a very good session. I enjoyed the interactive nature of it. Don't like just to be talking heads all the time. So it was good some of the folks who were listening in raised their hands and had a few things to say with us, to us. A lot of good ideas. lot of challenges too. And thank everybody for what they do on a daily basis, and look forward to seeing you again soon. Bye-bye.